Perfect. So
I agree.
To stay a bit informal, I'm a pleasure to introduce now Fabian Volk. He's professor at the University of Jena, or the University Jena Hospital, I think it is called. He's the professor at the ENT department, and I'm very impressed about his scholarly work. So when you look at Google Scholar, he's publishing every month or every week, and so he's very scientifically active. Besides his clinic work, and in his clinics, I think the most interesting part is facial paralysis, where one topic is to stimulate and activate the muscles after paralysis. And this was also the way how we crossed. So before I came to the US, both of us were sponsored by industry, and I could spend 1 week in Jena, or a couple of days, where we stimulated these denervated muscles. And after Justin and I were talking about taking this idea on to preserve the muscle tissue, I thought, okay, we have to invite Fabian because he knows all of this and he has a lot of experience. And so I'm happy when you tell us now about rehabilitation of the paralyzed facial muscles with or by electrical stimulation. So Fabian, it's up to you.
Thank you very much. Thank you for the invitation. It's a great honor for me. Thank you for the kind words, Matthias. We already heard my title. I've already shown the slide from my town where I'm based. It's Jena University Hospital. It's around the corner, close to the rainbow. But this is a city center. Even the city center is nice and green. And the big building in the middle is an old factory of Zeiss. And that's perhaps the only reason Jena is a little bit known in the international world, because Zeiss makes very good microscopes for operation theaters, but also for tanks. And so they will be in use. But today I want to speak not too much about optics, but more about my facial nerve center. Under the guidance of Professor Guntinas Lichius, who is interested in the facial nerve since 30 years, I was happy to build up a facial nerve center here in Jena. And we have an outpatient department where we can do diagnostics and therapy, like Botox injections. And due to COVID-19, we are, even in Germany, we have started to do some telemedicine, what works also very well because webcams are good for visualization phases. So I can do most of my examinations even by telemedicine. We have a special biofeedback training. I will tell you a little bit more later on, where the patients come to Jena. We offer surgical therapy, and we have a great interest in research and science. So we try to gather data from all of our patients, and the patients are very interested in sharing their knowledge with us. So yeah, there's a constant stream of publications coming out of it to share this. So our focus is not too much surgery, but diagnostics, comprehensive diagnostics, optical, questionnaire, psychological, then personal counseling to find out what is really the problem of the patient, provide him individual therapy, and do all this in a research environment that we get this data to share it with the community. So over the years, we have built up a lot of cooperations, but was even with our small team. You see here, this is my facial therapist, the speech pathologist, this is an assistant doctor, and this is the head of our department, Professor Guntinas Lichius. And most important for today is the cooperation with Vienna Medical University, where I met Matthias Kren and Winfried Meyer. When looking into the face of a patient, you see the skin, but you are interested in the actions below, so the muscle action. And to get an idea about it, we do photos, standardized pictures, small videos, 3D videos. So you can do a lot by optics, but you can do it also by expert ratings. You can ask the patient to rate their movement, so patient-related outcome measures. we put in needles to get information by the muscles. And we started to do ultrasound of facial muscles, but it's a very nice tool because it's much easier to do than putting the patients in the MRI, where you can see the muscles also, but here you can see them even in movement.
Sure. Okay. I need to see this conference. Is that okay? I have to
say it again?
40 minutes.
Was it a question?
Fabian, you are muted.
Okay.
Sorry, Justin.
So here are some of my patients, just to show you the variety of different cases. So some with incomplete palsy at rest, you see nearly nothing. Only if they move, you see slight differences left to right. You have acute complete ones. So there was a tumor destroying the whole facial nerve from one day to the other. So in the rest, because she was young and had good connection tissues, there was nearly nothing to see. But when she moved, you see that there's no movement at all. If you get older, if the paresis get longer, then the soft tissue will melt away. So you will see it more obvious. The corner of the mouth will fall down, and in movement, it will get even worse. But then here, the last case is also called facial palsy. Actually, it's a synkinesis, so it's just the opposite. So after a nerve damage, when there was not enough tension in the muscle, the regrow happened, and then there's too much. So this patient has now a smaller eye, and the eye is closing when he tries to show his teeth, and the nasolabial fold is deeper on that side. So there's more tension on that side. Do you know the term synkinesis? Is it something common?
Yes.
Okay, very good. Yeah, because it's in some fields it's completely normal, so we can go fast about this. So if patients with acute paresis come in, we do a workup, we look for tumors, we look for strokes, and if nothing is found, 70% of them will recover very well. If we give them prednisolone, sometimes some antiviral drugs, we take care of their eye, and then it's a fast thing. Fast means 6 weeks, sometimes up to 3 months. So anyway, a painful time for the patient, but good chance of recovery. But 30% of these patients don't recover completely. Some of them will get against this synkinesis, this misdirected reinnervation, but less than 10% will get a chronic denervated ones. Mostly cases where perhaps a tumor was destroying the nerve or where a surgeon was cutting it. And these are the ones where the electrostimulation at the moment is used. Anyway, I will start a little bit with the synkinesis, but very fast. So to reduce this high tone, you could put Botox in. That's a standard therapy. Botulinum toxin injections every 3 months to reduce the tone. But you could also try to retrain it. So the easiest would be to open it up and put the wires in the right place. But this is, due to my knowledge, not possible or hardly possible. So instead, we try to train the patient to change the movement patterns, central movement patterns. So by this biofeedback training. So specialized therapists, normally 2 patients sitting to each other. During COVID, it was 1 patient and behind a glass wall. And to do good research with it, we did a time period before 3 months, then the training for 10 days, and then another 6 months, sorry, and another 6 months afterwards. And hopefully most of the effect would be seen here and not in the waiting time before and after. I will go through fast here. And the face is 23 muscles. Here it's only 2 muscles reduced out of simplicity. And the green ones are for blinking. The blue ones are for smiling. Nerve damage, a regrow. And by regrow, some of the nerve fibers will not reach their target. Others will reach the original target. And others will reach the wrong targets. So this is a typical case of synkinesis. And perhaps you have seen even these. This patient is trying to close her eyes and accidentally she starts a little bit smiling. Here's when she tries to smile, her eye is closing. Now this eye gets lost. And here are some wrinkles in the platysma. So some nerve fibers actually going here are misdirected, going up here and there. And yeah, by Botox you can reduce it, but you can also try to retrain these patients, and both is working. And here are the results of this retraining. This is only the visual interpretation. So we took pictures from this patient and blinded data was creating these pictures. And start from the last picture, the composite score was not changing in the waiting time between T0 and T1, but there was significant improvement between T1 and T2. So this is in our training period, and it doesn't change too much in the waiting time afterwards. So this is a strong proof that is a strong hint. So we have no control group, but it's a strong hint that the training is effective. And also since synkinesis goes down, here down is better, and here up is better voluntary movement. But this was also
what is the training?
The training is surface EMG. I show you here. Oops, sorry. Surface EMG to get really the muscle completely relaxed, and then slowly build up single movements. So train the patient, try to smile, but stop the smile movement at the moment the eye is closing, and then go back, reduce the tone again, and then start it again. And at the moment the synkinetic movement occurs, then try to reduce this. So we hope to improve the feedback loop, that the patient is able to feel every muscle and target every muscle. Even if they're wrong wired, they have to relearn which nerve fibers now activate which muscles. And it's a long process. So we have only 10 days where we do this every day, but then we send some patients home with homework, and they should get used to it and should get habits out of it. Partly it's also reducing the tone on the healthy side. So if you smile and you want a beautiful symmetric smile, instead of smiling here very strong, you can smile on both sides gentle. And that looks much nicer than a maximum smile on the healthy side and a weak smile on the other side.
Because I think it's very difficult because our facial movements are not very, let's say, cortical controlled, or yeah. Because everything is happening really unconsciously, what is happening in the face.
Yeah, even babies can smile. So the movement patterns are really deep into the central stream. So you can improve them for if you have an artificial smile, but if you have an emotional smile, it will be at least take very long. Perhaps it's even impossible to get really an emotional smile changed, because the patterns are deep digged in. But yeah, we don't know. The patients feel happy. The patients are very thankful, especially this relaxation, that they know, oh, I have to do, this side is now under tension, I have to go lower, I have to relax them much more than the other side, and then it's equal. Because here, 3 nerve fibers activate one muscle, here is only 1 nerve fiber, so I have to go here, it has to feel, have to calibrate or reset to get normal. But yeah, not it's a very interesting field, but not the main topic for today. But yeah, perhaps next time.
All your research is interesting for us.
Denervated muscles. So the muscle of this patient by a tumor was completely denervated. So how do you get it reinnervated? You can try to bring activity from the healthy side, cross-face procedures. You can connect it to the chewing muscles. You can bring new muscles from the leg to replace muscles who are no longer there. But one of our main working horses is the hypoglossal nerve. So cut the hypoglossal nerve like you see it down here, 1/3. So that's a chewing function. The tone of the muscle is still active. But by the nerve graft, we bring up some activity, some axons into the main stem of the face, of the facial nerve, and from there it can innervate all muscles. And that's really the charming aspect of this operation, that the tongue, what has a big representation centrally, can reinnervate all muscles, and then the patient has to learn, because it's completely odd, but he can learn. If I move my tongue in that direction, it looks like a smile. If I press my tongue against my teeth, my eye is closing a little bit. This is a long-term goal, and the short-term goal is to innervate the muscles, to bring tension in it and stop this atrophy. So this muscle atrophy can be stopped very well with it. because the patient is always using his tongue, so is always doing training, even if he don't know about it. Accidentally by speaking, accidentally by swallowing, he moves his face. And it looks very natural. That's a funny thing. Even if you don't know about it, when he speaks, his face is moving. It's a synkinetic movement, so it's moving with his tongue, but in a natural situation, it looks very normal, because if he speaks a lot, the face is moving a lot. Different to the healthy side, but at least there's movement in it. So I like it more than, yeah, but no one knows if it's really the best therapies. There are big debates about it. Also not my topic today. Choosing the optimal therapy would be interesting. Detecting reinnervation, because some of these lesions, you have the neurosurgeon, for example, after vestibular schwannoma, tells you, I haven't touched the facial nerve. The facial nerve will recover. Don't worry about it. Just wait. But how long do you wait? Do you wait for 3 months? Do you wait for 3 years? What is the perfect timing for the reinnervation procedures? Then what is the maximum time till there's an irreversible atrophy? So if I wait for a year, there's a good chance that if I do then something, that after 2 years, the new nerve fibers, perhaps from the tongue, will still get some muscles. But anyway, 1 year, the muscle was only going down. That's really not optimal. And even if we have only short distances in the face, I think in your case with arms and legs, it's all much worse. So a rule of the thumb would be maximum 1 year. After 2 years, you really get only moderate results. There are some colleagues here in Germany who already after 6 weeks, after 6 months, get cold feet and start to push the patients to the operation room. I try to wait a little bit longer because I've seen nice recoveries after a year, but we also do needle EMG to detect first signs of reinnervation earlier. And if there's a vestibular schwannoma operated, you can also do the small muscles around the ear, because then you save 10 centimeters of reinnervation time. So you get the results from the ear in EMG much earlier than in the face, because of the growing distance. You can also use CT to see the muscles, if there are muscles, or ultrasound, like here or like here. And now Vienna comes in. Winfried Meyer, the supervisor from Matthias and the mentor also from me. And he showed us these slides from the RISE study for denervated lower extremities. And that was possible by electrostimulation to rebuild denervated muscle to nearly normal. So this is this last column. Here's an electron microscopy of a normal muscle, healthy control. And after 15 months of denervation, all the structure of the muscle is nearly lost. But after 2 years of electrostimulation, you can get this structure back. And this was really something very surprising for me. And I was saying, wow, that would be great if we could do something like this. Is this possible? Here another graph where a patient started to stimulate, and they segmented the femoralis, the rectus femoralis muscle from the upper limb, Oberschenkel, also lower limb, but upper part of it. Yep. And the volume and the density was going up, but then the patient got lazy and stopped the electrostimulation, the daily electrostimulation, and then the muscle was going down again. So it's really, it's not, if you don't bring reinnervation in, it's only a temporary solution. But that's not too bad for us, because we often want to wait till we know if reinnervation occurs, and if not, we have reinnervation procedures like this crossface or like this hyperglossus to bring in. So it would be nice to get 1 or 2 years extra. But electrostimulation of the face is often claimed to prevent reinnervation. So there are really a lot of doctors who remember, don't do electrostimulation in the face, it stops reinnervation. I was saying, whoa, I don't want to do anything so bad for the patient to prevent reinnervation. And the same doctors often tell me, and it also makes synkinesis more worse. And I was saying, well, can you show me any publications about it? Because it's strange. How can it, on the one side, push down the reinnervation, on the other side, make the aberrant reinnervation higher? What is true? Is it pro reinnervation, but mix it up? or is it preventing the axons to grow? So I was a little bit, frightened by these stories I heard, but checking the literature, I found nearly nothing good pro or con, only some good animal studies who show that if you don't do 23 hours electrostimulation a day, there's little chance to damage anything. So if you do really, really a lot of electrostimulation, then perhaps, but if you do it in a moderate way, twice a day, renovation should still happen. So at least in animals. And then we were brave enough to start electrostimulation, at least in some cases, but we choose the very severe cases. So cases where we really cutted the nerve, or the nerve was cut by someone else, and we did this renovation procedure. So we were aware about that this patient will have synkinesis anyway. So we were saying, let's try it. There's a good chance it will take months to renovate. If this muscle is in a better condition, the patient has a benefit, and the risk of preventing renovation is not so high. Let's just start it. And we start with a small handheld device, the Parese-Stim. It can only do 1 impulse per second, or between every impulse there's 1 second gap. And it looks like this. So the electrodes are big, 6 centimeters to 4 centimeters, but even these big electrodes are good enough or possible to use in the face. With Winfried and Matthias, we also played around with smaller electrodes, but these are the only ones who are officially allowed to use, and they work. So they are fine. The patients can put them, one in the upper part, one in the lower part, and you can see this nice movements.
And so can I ask you, can I ask you, of course, you have a healthy trigeminal nerve, so they have normal sensation of the face. So how is their experience of that stimulation? Is it uncomfortable?
Yes. The first is like a clap in the face. So it really feels like so the patient goes, oh, wow, that's like, that's uncomfortable. But the second and third already they get used to it. So it's only, so it gets something very normal. So you have to be careful to start with them, tell them, so here's a button, you have the control, put the start button, and then they say, oh, wow, that's a lot. And then the second one is already fine. And then after a few minutes, they start to put the increase button and go up with the intensity. And so it's really, they feel everything, and the face is perhaps more sensitive than most other areas of the face. So I was very skeptical about this because it's trigeminal nerve is completely working. Yeah. Also, we have optical sensations, so they see so like small lightnings every time they stimulate. Some of these patients have this, that the retina is depolarizing, and they have sometimes a metallic taste on the tongue. So also the sensory nerves are very unspecifically stimulated.
Okay. And so the sensation that they perceive is really the contraction of the muscle. It's not the burning, tingling of electricity.
It's both. It's they have sensation directly under the electrode. Okay. Even with this triangle and impulses, we haven't found, even very long triangles, we haven't found a frequency where we could sneak in without any sensation. Okay. So it's always a little bit sensation. So it's not, we had the hope that if you go very slow, very flat, that we could perhaps bring in enough currents that the muscles react, but the patient feels nothing but the muscles. It was not possible. Okay. So they always feel a little bit in the skin, but the skin is normally innervated, so it would be a wonder if they wouldn't feel anything. Okay. But it's uncomfortable in the beginning, but they get used to it, and after often there was one patient who was not able to go to numbers where I was happy with it, where I say, oh, a little bit more would be better. All other patients, after 5 minutes, they're happy with it, and they increase the amplitude till they get a nice movement. And then they feel the movement, and then they feel the contraction of the muscle. And if they see it in the mirror, they're really happy about it. They really say, wow, that's, wow, why is it moving? What is going on? And then I have to stop them. It's only electrostimulation. It's only stimulating the muscles. That will not do anything to the nerve, perhaps, hopefully, but it's at least it will hopefully keep the muscles in a better shape.
Okay, and never any tissue damage, no blistering, no burn, no. This is a lot of energy, right?
Yes, it's a lot of energy, and the face is very important to not create big burns. I had one patient who had some problems with acne, what is acne called in English?
Yeah. Pimples? Pimples in the face?
And if one of these things happens under the surface of the electrode, that becomes painful because there's already inflammation and more blood flow, and then all the current goes through this point, and it's already painful before. So she had to put it on a different place, or have to wait for 1 or 2 weeks till it's fine. But this was not triggered by the electrostimulation. This was only the electrostimulation made the pain worse of the inflammation in that area. But all other patients, you have to be careful to change the electrodes from time to time. That's only 1 or 2 weeks. Some patients, if they are lazy, they take the same electrodes and then they get dry and then they fall off. And at the end, you have a small surface where a lot of energy goes through. The machines will stop it. But anyway, there's a good reason to take these big electrodes to bring the current in over a big surface, and not too small.
Yeah.
But we were playing around with small electrodes and we were not burning anything.
And Gerd, we have another group from Mexico who has joined us. And one of the comments I wanted to make about this is there's a lot of studies that have been done who've been using wrong stimulation parameters. They've been using the things that are available over the shelf here in America that are TENS units and so forth that really have no appreciable impact on the muscle, and that this is very different. But what I'm also seeing is you have nice, neat little handheld devices. Is this company, Matthias, that you told me about?
No, these are both from Kraut und Timmermann. That's in Hamburg, a company. There are 3 different companies I use devices from. And I've contacted 2 of them, and both of them said, no, sorry, we don't have an FDA approval. So I have one chance, but I doubt that the Stimulat from Schufried will have a FDA approval. So they all CE marks.
So these you can reprogram them to the triangular waveform at exactly what you want with these devices?
Not all I want, but they have these as presets.
Okay.
Some of them have longer gaps. The best would be really to program everything you want, and nice would be if you could change it. If you could start with long impulses for 5 minutes and then go to short impulses and then go back to long impulses, so the patient don't change the programs. That would just be run automatically. But I haven't found a device doing this, even the new ones. But MedL will bring a new device next year, so hopefully.
Okay.
And they could have FDA approval then?
They don't do an FDA approval.
It's very unlikely.
I talked to them.
Don't forget them.
But perhaps we can push them, or we can. In Germany, some ethic committees allow that you use things who don't have a CE mark, so who have only an FDA mark. So perhaps we find someone doing the same the other way around. Say if it's something established and if it's only in a study, so they will not be able to sell it, but perhaps we can use it for the study.
Yes.
That would be a nice way to do it. And it would be cool to give the patient the thing to take it home, to do it really every day or twice a day.
Is this what you're doing? Are you sending your patients home, or are they only doing it at your clinic?
No, they do it at home. Yeah. That's a trick. The devices are small. And some of these devices you can also get to your local physiotherapist, but that's once or twice a week.
Yeah.
In contrast to these devices where you can do it in the morning and in the evening. And I had some patients who was doing it 3 times a day and or constantly while they were working. I was saying slowly, we don't know how good it is, but yeah. Renovation time. So we were looking back into our patients, and we have here control groups, the blue ones, who got the renovation from the 33 patients who had no electrostimulation. So 30 of them renovated, and in the median, the curves are similar, even a little bit in favor of the electrostimulation. So we are not worried about that electrostimulation prevents renovation, even if the patients do it every day. But it's good. I don't believe that it makes it faster. It looks like here on the graph, but it's a retrospective study. So perhaps I've seen the patients who don't do electrostimulation not so often, not so regularly, because they don't have to come in to get new stickers and things like these. So this could be a bias, but at least it's not preventing, and it's perhaps even promoting it a little bit. Synkinetic outcome, similar study, but other patients.
Fabian, yeah. How long was stimulation in these 6 cases or 7 cases?
It was 17 months, so really long. So so we started when we were seeing this denervated case, when we were doing the renervation procedure, and when there was partly renovated, we often were just continuing to stimulate. The idea was that if we stimulate, we still see these movements, then at least a part of these muscles are still denervated. And then my question was why should I stop? Why not keeping the still denervated muscles in a good shape while the nerve is regrowing and hopefully innervating the rest of it? And it worked. So it was very aggressive.
You begin before surgery and you continue until full recovery. Is that right?
Depends on the patient, how they come. But often, if I know, nowadays, I start as early as possible. If I see a patient do the EMG, see no activity, or I read the operation report from a colleague in Berlin who told me, I cut the nerve, I resutured it. Can you do anything for my patient? I say, okay, I do some pictures and I give you a prescription for the electrostimulation. And hopefully what he has done is already perfect because he has resutured the nerve. There's a good chance that it will grow, but you will not fall into this deep valley for 3 months, and then hopefully it goes up again. We can perhaps make it a little bit more flat, keep the muscle alive. And it has also a psychological effect. The patient like to do something. They don't like to wait 6 months and hope that something is coming and doing nothing, but a little bit eye care. So it's really, they feel to be part of the process. And the patient tell me it's easier to eat and easier to speak if there is a little bit more tone on the muscles. It's not also so weak. So after the stimulation for a few hours, the muscles are in a little bit better shape.
And do you see that in these 6 people who have then re-innervated, that the muscle tissue looked stronger or more preserved, or was it not so different compared to the other?
That would be the quality. This is another.
If you go to, I can wait.
Yeah. So these are patients who got electrostimulation. We did the grading at least 1 year after the renovation occurs. So we want to see the final outcome. If the synkinesis are really stronger, if the paresis looks different. And the only significant difference we see in the synkinesis, so what we were afraid of. So synkinesis is a significant change, but luckily in favor to us. Luckily, the synkinesis were a little bit lower. Again, small numbers, I don't believe it too much, but at least there's no hint that is against us. So this is this E-phase score. There's a nice tool from also from Harvard. And there's one significant change in the synkinesis score in the mid-phase region, exactly where we have stimulated, and they have less synkinesis in that region. All the rest is, it's not significant different, but it is, more or less a little bit random. So the patients are not the same. So the next step would be to do a prospective study. And that's what we are, have started now. So we did ultrasound of some patients, and we hope to find in the ultrasound on the MRI some difference. But due to the small sample size of 5 patients, now we have 13 patients included, it's still nothing systematically where I can see, oh, the muscles look much better. But at least renovation is not prevented, and we see a little bit less synkinesis, but I would be careful with it. So
there are no cases in which it performed worse. You feel like you can eliminate that as a concern at this point. You're never going to hurt your recovery of your nerve by stimulation.
No. Okay. I had one patient who phoned me after, I think, 6 weeks and told me he's doing electrostimulation and she sees no movement. And so I stopped the electrostimulation and called her in And then we said, okay, we make a gap for 4 weeks because we perhaps were increasing the stimulation parameters too fast. And Winfried warned me that there could be a muscle fatigue. So if you do an old muscle or a long denervated muscle, bringing too fast, it could be that they run out of energy during the stimulation, and then the performance breaks down. Then you have to wait till they recover. That happens in one patient, and then after 4 weeks or 3 weeks were left, and then after 3 weeks we started with longer impulses, and then we were slowly getting back in track. So then that was the only thing where I think, okay, so I made a mistake. On the other side, I'm happy if I would show you the graph here. This is the patient, the red one. This patient number 3 in the study. She had 16 years of denervation, so really denervated muscles. I think these muscles are partly renovated by perhaps the chewing muscles or by vegetative nerve fibers from the blood vessels. There must be something, otherwise there would be no reason to get any muscle stimulated. But when we started stimulating, we have seen nothing. And I was like, okay, just take it home for 4 weeks and come again. And after 4 weeks, or she already called me 2 weeks later at home, there was some movement. I was like, okay, we will see if there really movement. And when she came in, there was really movement in the right direction. And in her case, we started the red case. We started with this 500 milliseconds, and then we were going down too fast, perhaps. And then here after, sorry, where is it? Yeah, after 20 weeks, we were going too fast. And then he told me, oh, if I start stimulating after a few minutes, the muscle stops completely to move. And then we were slow, decrease the number of impulses and then go back to normal. So why is the parameters important? The phase duration. If you have a long phase duration, you put more energy in it. It's perhaps a little bit more dangerous. But on the other side, you lose time for training. So if you have, like here, this 250 milliseconds, it's 250 positive, 250 negative, and most machines have at least the same time as a gap. So you have already only 1.3 hertz. And then most machines have this on-off circles, 3 seconds on, 2 seconds off, or 5 seconds on, 1 second off. So it already goes down, and then you do stimulation, 5 minutes stimulations, 5 minutes pause, 5 minutes stimulation, 5 minutes pause. So, and this in the morning and the evening. At the end, you get only 1,440 stimulations, contractions per day for the muscle. So if you would be able to compress everything, if the muscle is healthier and needs less energy and can cope with sharper stimulation impulses, like here, you can already increase it. So it's already more than double the contractions. Because I think at the end, or as far as I've understood it right, it's important to get as much stimulations as possible. So the muscle needs these contractions to get normal, to get training. So shorter would be better. Can we quantify it? The patients feel happy with it. The patient-related outcome measures get better, so they feel happy with it, but that's perhaps could be a placebo effect. So we were asking, we were taking pictures and we're asking blinded raters to rate the faces, and the strongest effect we have seen here in this picture, where all raters were convinced that there was a little bit of positive effect. Stimulation, picture, stimulation, picture. Only perhaps in 2 hours difference, or 1.5 hours even. And you still see this, the red areas in her face. These are the area where the electrodes were. So it was really shortly after. And really the corner of the mouth is a little bit higher. Sorry. And the eye is closing a little bit better. So these are both the same, because if the cheek is a little bit higher because of the stimulated cheek muscles, then the eye is not pulling down so strong. So it's the same effect. It's not so much that the upper lid goes better. It's more that the lower lid has less tension. You see here it's a little bit bended outwards, and here it's getting better. So there's another study with 3 completely blinded raters running with an automatic rating system running in the background, and automatic presentation of the pictures, and we hope to can show this also over time. So at the moment, we are really happy with electrostimulation. We try to give it our patients as a gap filler to keep the muscles alive until renovation occurs. And we have 1 or 2 patients who are so happy with it that they say, no, we don't want any other renovation operation. So this is perhaps a little bit the downside. Do we really want this? Do we want them to give a device to keep the muscle in an acceptable stage instead of providing them a good surgery, what will really help them in long term? But yeah, but most patients take it as a helpful device in between.
So this is now becoming a normal part of your practice. Everybody gets a stimulator.
No, only persons where I find nothing in EMG. So most of my patients are still the ones where there's a little bit renovation or there's acute inflammation, and I don't touch these patients at the moment because they have so good recovery, and it's still money, it's still a chance of malfunction. So I only do the perhaps less than 10% of the cases.
This bottom group, but everybody who has lost innervation, everybody who has a divided nerve that you would consider surgery for, all of them get this.
I have a device in my drawer in the outpatient department, and I offer it to the patient, and I do a test stimulation. And if they say, no, this is too painful, I wouldn't go further. But till now, only 1 in perhaps 50 or 60 patients were saying, oh no, I don't like it too much. Most patients say, oops, this is painful. And then the second and third impulse is already fine. And then they are looking in the mirror and say, oh, wow, cool. My face is moving again. So it really works very well. Yeah.
Perfect.
Then it's always a little bit of hassle with the insurance companies. So it takes some weeks till they get it. And sometimes the renovation already occurs before, if the patient is lucky, before the health insurance company provides the stuff. So I'm happy if I can do it in a study, like this study with MedL, where I can put the device out of the shelf and give it to them. So it's I can immediately start, and then I have the whole period as for the study. Otherwise, the retrospective patients are always a little bit, you never know how fast they can start.
Yeah.
Okay, that's it.
Okay, I have a few more questions now. Do you, of course, the most exciting area of this to me is this idea that, can you go back, in your experience, have you stimulated patients that are beyond the window that you would ever consider primary nerve surgery, that you would bring their muscle back to health and then have a successful result? Do you have examples of this?
I have this one, or I have 1 or 2 patients like this one in the study with a 16-year denervation, but she was not interested in a renovation operation afterwards. Okay. So I don't know, the tone was increasing, the face was looking better, but I don't know if these muscles are now in a shape where renovation would be better. That would be something that could be solved over time by some cases, but I think it would be more fast forward to do it in an animal study or something like this, to really have an example where you see in a control group after, in rats, perhaps a year, there's very pure renovation by electrostimulation, and then doing the renovation, you get results similar to early renovation after 3 months. Something like this, but perhaps the better way to do it. Okay. I hope there's a hope, but I can't prove it.
Okay, so you would try it if you had a patient who is agreeable to it, but you just haven't had the opportunity.
Yeah. And I would do ultrasound, I would do the electrostimulation. The electrostimulation is also nice to show the patients that there is muscle. A lot of my colleagues tell the patients, oh, it's 6 months ago, there are no muscles. We have to do a free muscle transfer. We have to take the gracilis muscle and do a huge operation. Then I was like, oh, it's 6 months. Isn't there a chance that we can use the muscles you still have? Yes. If you then do electrostimulation, the patient, the EMG is complicated. No one knows how to interpret it. But electrostimulation, you see, oh, wow, that's exactly the movement I want. So there seems to be muscles.
Yes.
And even a surgeon without any EMG experience should be able to detect a smile.
Absolutely. Now, this is a debate that we talk about regularly in our clinic, and the basic science seems to show two different problems. One, of course, is the degenerated muscle, which this clearly solves. The other that's been proposed is that the distal nerve is the most important factor, and that you cannot get an axon through the distal nerve to the muscle if too much time has transpired. But our clinical experience is that you can get a sensory axon through anything at any time. So why can't you get a motor axon through it? For example, if we do a procedure for the bicep way too late, we may not get the muscle to contract, but the sensory fibers will grow into the bicep such you squeeze it and you feel it in the hand. And so it seems like clinically this theory doesn't hold up. I don't know what your thoughts are.
I'm also skeptical, This idea that all tubes are blocked.
Right.
Yeah, it's not my main field. I've heard the theories, and I think this should be solvable by good animal experience.
Yes.
But I wonder about it. I could more wonder. It would be interesting if you stimulate the muscles, if it would be necessary to, or would be useful to stop the stimulation at the right time. So if you know now the nerve fibers have nearly reached the end plates, would it then be useful to stop the electrostimulation, that the muscle gets more in this denervation mode again and is crying by sending out neurotoxins, neurotrophil factors to collect that would be interesting. But till now, I was just go on stimulating, and it didn't prevent anything. And so I feel comfortable with this, go on with the stimulation. Because it's not so much stimulation. It's only 2 times a day for 15 minutes, in contrast to a daily work of 20 hours of facial movements. Even by sleep, you move your face. So these muscles have a high workload normally. And I was not able to inverse it, to bring up the muscle to normal. It was in contrast to the Winfried Meyer. Winfried Meyer was able to, the RISE project, they were making the muscles bigger. At the moment, I'm only slowing down the atrophy, hopefully.
I see. But this patient who came at 16 years, you couldn't generate a
in her case, I think, in her case, I think we were already at the bottom, and in her case, I think you're right. And I have examples where an ultrasound from 1 week to the other 4 weeks later, it looks like an increase. But in average, it's not out of the dust. So it's not clear improving. Not as nice as I hoped.
For the comparison to the RISE project, they started with chronically SCI participants. So they had a lot of degeneration or atrophy already. And in your case, you start from a kind of healthy muscle and want to preserve it. So you cannot have growth, or it would be very difficult to have growth for 2 hours of stimulation.
Yeah, exactly. Yeah. So
from your level where you start.
Here in this patient, the one with a very fresh, the yellow one, only 15 days of denervation. And she was so good in the beginning because there was perhaps even working end plates. So perhaps it was not muscle stimulation, but perhaps it was really still nerve stimulation. Yeah. But then 4 weeks later, all neurotransmitter were gone. And then it was really muscle stimulation. Then I had to go up from 50 to 100 milliseconds to make longer impulses to get a good contraction.
Now, it was my understanding that these stimulation parameters will not excite an axon. They will not cause a contraction of an innervated muscle. Is that not correct?
Yes. Yeah. The long ones, that the 100, 150, 200, they don't create contractions. Really funny. I did it once. I put it on the paratic side, and then took the same parameters on the other side, and nothing happened. Only a little bit contraction you see on the other side. But here, this small impulse, this slow up and down is a healthy muscle, a healthy nerve can cope with it without getting depolarized. Yeah, you're right.
So no contraction at all.
If you go very high, the amplitude, then you can create. If you go very short, then even triangles become very steep. But yeah, if you go very flat, then it's very selective. Yeah. And that's also good because in the beginning, when you have long impulses, the chewing muscles are not affected. If you get more and more healthy, and it gets deeper, then the patient starts clapping his teeth, but it's not so comfortable. So you have to go with electrodes very much to the front, so don't activate them, etc. Or they have to close their teeth. So voluntarily close it a little bit. But if they have it loose and then start, it's not so nice.
Well, perfect. Well, this has been perfect. And I would love to keep in touch as we begin to move forward with doing this in the arms of our patients.
Yeah, if you have partly denervated muscles, it would be very, very interesting to put electrodes on top and see if only the denervated part should be activated. And the healthy ones around should be,
Winfried had a nice video of this in a spinal cord injury forearm, where he would do the one parameter and some of the fingers would go up and they would move it to the stimulated muscle parameter and the other fingers would go up. And so it was selective based on how you receive. I thought that was really fascinating.
Yeah. And I think it keeps the motivation up for the patient. If they can see there's still hope, the muscles are still active. So keeps them, don't give up hope, still do the training. But also keeps your brain thinking about this part of the face or part of the body in your case. A lot of my patients completely forget their half face. So it's a peripheral lesion, but they have a kind of neglect. So they are so focused on the healthy side, they only chew on the healthy side. And then I have to tell them, oh, please, if you now have renovation, try to train both sides because that makes your face more symmetric. This is every time you would eat, it's kind of training for you. Yeah. And so perhaps as electrostimulation, this 3 months of electrostimulation or 6 months helps the brain to think about the paretic side. No, it would be very, very, very interesting to see how these parameters work in the in different areas, because I think it's only a benefit. So in my case, 3 months of renovation, perhaps 6 months, it's still, you can still risk to wait. But in your case, you are so much more in a hurry, so don't lose the muscle. So I really, it would be very interesting to keep them in a good shape and then do the renovation procedures and then hope that if the renovation comes back, you see, have a good muscle and at least a faster recovery, perhaps even better entry side, I don't know, but at least it should be easier to start with a good muscle instead of a completely atrophied muscle.
Absolutely. Well, thank you so much for your time. This has been very, very helpful, and we will definitely be continue to communicate with you, particularly over these devices, because that looks much easier to use. And the Matthias, we have this massive box and things going on. I like yours.
Well, it's really good to have something the patient can take on.
This is the best that we can do currently, you know.
I need a wagon to pull behind my patient.
And Fabian was also working with the BioBag. And I think this is our only chance currently, but we will see to find the best thing.
Perfect.
My whole office is full of these devices, so yeah.
Perfect.